Dr. Gaston is the Vice Chair for Translational Research at Riley Hospital for Children. He went to college and to medical school at the University of Virginia. He did his military service, the USS Iwo Jima, and pediatric training in Bethesda in the United States Navy. He trained in pediatric pulmonology at Boston Children's Hospital and has been continuously funded by the NIH for 25 years. He's currently a PI on several grants, including a PO1 to study asthma and CF, the Precise Asthma Intervention Trial, and R61 to develop a novel respiratory stimulant, along with several smaller grants. He has over 200 publications and over 10 patents. He has also helped to found several companies focused on translating discoveries for the benefit of children with respiratory disease. And of course, he and his wife have 3 children. So with that, I will hand it over to Dr. Ben Gaston. You can take it away.
Wonderful. Thanks so much for that kind introduction, Aaliyah. I was enjoying Dr. Suezo's talk, and I had to jump around back between Zooms, but now I'm here. Share my screen. And go full screen. Let me know. Can you see that okay? We're
Yep.
good?
Perfect.
Great.
Yep.
All right, terrific. Well, thank you so much for the invitation to speak. I think that Dr. Klepfer and Dr. Suezo and several others have set this talk up well. We're going to talk now about some of the most difficult to treat asthma and sort of the final step in that GINA or NHLBI EP guidelines stair step. And we'll talk about specifically asthma that's commonly life-threatening or requiring a lot of corticosteroids. And we've seen before the characterizations, the ways that we make that diagnosis of severe asthma. As far as conflicts, I will not recommend the clinical use of any product from which I could profit, but I will recommend consideration of research studies on which my group is funded by the NIH, in particular the Precise group. So I want to start out with providing context so that if people are interested in learning more about any of these interventions that I'm discussing, or more in general, you can reach me, and that's my email. And also the coordinator, I see that she's come up so that her camera is on. That's Lisa France, who's the coordinator for a number of these studies, and can get you in touch with the right person if you're interested, or specifically interested in Precise. And here are some links to the clinicaltrials.gov sites for some of these studies. I'd also like to point out that it's Lisa France's birthday, I think, and so happy birthday to Lisa. 29, I think. So this is the overview of the things I'd like to go over with you in the next half hour or so. First, it's treatment for severe asthma should ideally be personalized using precision medicine. And you've heard some about this already. Several novel therapies are being studied in Indiana and in the Indiana Precise Network. And I'll go over these. One important variable affecting asthma severity is sex. We've discovered that androgens may be important in some severe asthma patients, and that's one of the personalized aspects of severe asthma we'll cover. Another important variable is low airway pH, and we're studying a treatment that raises airway pH and actually may have some efficacy in COVID, but that still remains to be established. We also aim to improve on current practice standards, targeting the right treatment to the right patient with severe asthma. That will improve efficacy and also save costs. As you've heard, some of these treatments, particularly for severe asthma, are extremely expensive, on the order of $20,000 to $30,000 per year per patient. So many patients, particularly underinsured, simply can't afford current state-of-the-art personalized therapy for T2 high or eosinophilic asthma, even though these treatments are advertised on television. So this is the general idea. Some patients benefit from specific treatments and some don't. And so if you use one sort of one size fits all for asthma therapy, some over on the left-hand side of the screen have benefit, no toxicity, and some have benefits, and this is particularly true for corticosteroids and toxicity. A lot have no benefit and no toxicity, and no benefit and toxicity is the worst case. And I would include in toxicity cost. So a number of these have very high out-of-pocket expenses associated, even inhaled corticosteroids. If the insurance company changes their preferred vendor, or if you lose your insurance for a period of time, then the cost is also extremely high, not just the toxicity. So one of the things that we aim to do in our programs, and not just here, but across the country, is to do a much better job of matching the right treatment to the right patient. So these are some examples of the sorts of things that can help us to be sure that we're giving a therapy that's beneficial and non-toxic to the right patient. And so we can it's kind of like the Harry Potter sorting hat. We can sort the right person to the right therapy using things like eosinophils, which you see on TV, but also things that are a little bit more better targeting, including genotype in chest CT. So it all sounds great in principle, but actually executing a protocol to make sure we get the right treatment to the right patient, because of the complexities of asthma and the number of different asthma therapies available, is quite challenging. And Lisa France can attest that what we originally conceived of as a protocol is, in terms of implementation and doing it properly, is very labor intensive. But we are getting across this valley and through the maze and up Mount Doom and getting to our goals in many cases. And so I'm going to walk through that with you a little bit and how that process works for patients. To begin with, we've put together, really, NIH has put together a large network of different centers to collaborate on this effort to improve personalized care. This is the Indianapolis Center. The Indianapolis Center is actually the lead center for Indiana, for Ohio, for Virginia, and effectively for West Virginia as well. And we affectionately call it the Wabash and Chesapeake Collaborative. The objectives of this collaborative, in terms of developing better precision therapy, are to identify new therapies that work in biomarker-defined groups of patients with severe asthma, and to optimize treatment by refining the biomarkers and subgroup definitions. And I'll say here that, you know, it's a given that 60% or so of patients with type 2 or eosinophil high asthma will respond to commercially available therapies. And where our area of interest here is both for people who can't afford these commercially available therapies, but also for people who aren't in one of those high eosinophil or high IgE categories. Secondary objectives are to identify the best monitoring biomarkers for selective therapies and to expand knowledge of safety and effectiveness of selective therapies in pediatrics in particular, about which not enough is known. Our goal has been to enroll 800 participants across the country, and also in the UK. These will include adolescents as well as adults. Our lower age limit is 12. We are assigning interventions based on phenotypic biomarkers. So there's a lot of prior research that's gone into showing which patients should respond best to which treatments. And so we'll also have some patients who, of course, get placebo, that is, get something that that doesn't contain the active drug for comparison, and also patients who are biomarker negative who will get a drug that may be appropriate more for a biomarker positive person. But that's the nature of the study, is to sort out, is it really true that this biomarker is helpful and predictive? These are new therapies that are free to participants and hopefully ultimately less expensive than currently available therapies. There's an anti-IL-6 arm. Dr. Suazo mentioned that in his talk in terms of COVID therapy. That's not going to be inexpensive. That's going to be as expensive as it is for COVID for high IL-6 patients. But the other therapies are much more reasonable in cost. So the master protocol is to have common elements for all interventions with upfront planning and time invested in protocol design, modeling, statistical analysis, and it's what's called an adaptive trial design to make sure that the right treatment is given to the right patient. That is to say, if we get into the study and we're finding that intervention is not as effective for the people that we thought it would be effective for, as we'd hoped, then we switch to a different intervention and stop that part of the protocol. So this adaptive trial design is commonly used in cancer studies, but it's never really been used like this before in asthma. So it's exciting. It's been extremely successful in terms of developing the best cancer therapies targeted to exactly the right patients. And we anticipate that it'll be the same with asthma therapy. So let me just go through some of the therapies that are being studied in Indiana and the Indiana Precise Network that are part of the larger national program. These are chosen because there's strong data supporting the value of the intervention and the biomarker combination. There's strong safety data. Novel interventions are being studied addressing unmet needs, particularly in severe asthma, high feasibility and reasonably low cost and availability for adolescents in the case of two interventions in particular. So let me just go back. So one of them we've decided not to pursue at this time in the context of everything else going on with COVID and so forth. But there remain 5 interventions, at least for the beginning of the study, that we're using for which we're using targeted interventions. One is this KIT inhibitor, which is imatinib for T2 low, that is low eosinophil asthma. And there's some studies, one published by Dr. Israel in the journal, showing that this is likely to be efficacious. There's an anti-IL-6, and this gets to some of the biology that Dr. Suazo was talking about, particularly for people with high CRP or high plasma IL-6. There's an estradiol-glutathione reductase inhibitor, and we'll talk more about that in a couple of slides. There is essentially a bacterial extract that arises from the European studies and has shown efficacy in Europe, that showing that the microbiome affects your asthma severity, and so this particular one is called Bronchovaxome, and this is going to be the first trial in the US using it. And then there's a nutritional arm in which we ask the question, can you improve your asthma control just with a nutritional intervention, a dietary intervention, without having to use added drugs? These last 2 are the ones that are available and FDA approved for use in these pediatric studies and the adolescent studies. This is the Cavosonstat background, and I won't spend a lot of time here except to say that this pathway is extensively studied. Many patients with asthma, for example, will use inhibitors of the leukotriene pathway, either Xylutin or montelukast to inhibit the synthesis or the receptor for leukotriene. This is a similar kind of agent that inhibits the synthesis of inhibits the breakdown of an important bronchodilator and anti-inflammatory that's normally present in the airway, and that inhibitor is called Cavosonstat. We know that this will improve airway smooth muscle tone by preventing what's called cholinergic airway smooth muscle narrowing and improving response to things like albuterol. It'll also prevent inflammation in a number of models. And so we're using the genotype of this S-nitrosoglutathione reductase, or ADH5 gene, to predict who will most likely respond to this intervention. So, and there are similar sort of detailed background data regarding all of the other interventions that are being studied. Cavosonstat is just an example that I'm familiar with. So how does this protocol actually work? And Lisa France works very hard to make this really run perfectly. After initial screening and run-in, randomization of subjects to targeted interventions based on the biomarker profile, and that's done at a central data coordinating center in North Carolina. It's a crossover design with subsequent re-randomizations to other treatments. There's a 16-week treatment protocol and an 8-week washout between treatments, so that, for example, if you get Cavosonstat, then we wait 8 weeks until after you're done with that trial and before we start something else like bronchovaxone. There's a chance to demonstrate efficacy on any of one of the three outcomes: better lung health and lung function as assessed by spirometry, the classic marker FEV1, decreased asthma symptoms, and fewer asthma exacerbations. That's fewer episodes requiring systemic corticosteroids or increased corticosteroids or remission. There's also an important futility analysis. If the DMCC and the Data Safety Monitoring Board notice that a drug just simply isn't working for anyone, then they're just going to stop that trial. So that is a continuously monitored outcome. And so this is the way it works with pre-screening, then double-blind placebo-controlled crossover phase, and then on to subsequent phases. There are a variety of predictive biomarkers that we are looking at, including eosinophils, as you've seen before, exhaled nitric oxide levels, blood interleukin levels, including IL-6, specific genes, including the GS-NOR gene and other new biomarkers. Inclusion criteria, if you are thinking that this may be something that one of your patients or you are interested in participating in, this is really for adolescents over 12 or adults who have clear asthma and meet ERS ATS guidelines for severe asthma, and they're on stable asthma therapy for 2 months, which includes at least a high dose inhaled corticosteroids and a second controller, which can be one of the biologics, such as an anti-IL-4, IL-13, or anti-IL-5, anti-IgE. So if you're in another trial or have been in the last 2 months, then you're not eligible to be in this. If you have other chronic pulmonary disorders, if you're on systemic corticosteroids more than 10 milligrams a day because of the severity of your asthma, if there are other red flags in safety, that if there's any reason to think that any of the interventions would be unsafe, then you're excluded. And also if you have an extensive smoking history, you would be excluded. Okay, so that's enough on PRECISE, and that it is sort of a groundbreaking trial using some wisdom that has come from our oncology colleagues to optimize treatment for severe asthma. There are a couple of other variables I want to talk about before we close and before I open it up for questions. One important variable is sex. We've discovered, and we've known for some time, that sex is an important variable in determining the severity and even the prevalence of asthma. we have more and more insight into why that is. Now, here's an example of what that sort of thing looks like. So these are each dot representing one asthma patient. These are asthma patients in Cleveland on the left-hand side. You can see that in kids less than 10, there are more boys than girls with asthma in general. As the population gets older, this is cross-sectional, but these are insurance data, but as the population gets older, women begin to outnumber men in terms of who has asthma. This is also true for asthma severity. And the middle panel is our Severe Asthma Research Program and the NIH SARP-1-2 data. The O's are non-severe asthma, the X's are severe asthma. And so people with severe asthma also who are adults are much more likely to be women. Looking longitudinally at severe asthma and also asthma hospitalizations, we see the same kind of thing. And one of the things that we were interested in the SARP a few years back was to sort out what happens during this crossover period when asthma in boys seems to get better and asthma in women begins to get worse. So we were interested in sort of studying this period. And here's some of the results from those studies. To make a long story short, for both boys and girls during adolescence, asthma severity begins to decline. All criteria for asthma severity, including requirement for inhaled corticosteroids, admissions, symptoms, requirement for beta-2 use, those sorts of things get better as you go through adolescence for the most part. And boys and girls are about equal in terms of their improvement. So looking into this, Christy Ross in Cleveland did a lot of work on this, and in effect, and Mark DeBoer did as well in Virginia, and found that one of the important determinants is that both boys and girls during adolescence have an increase in androgen levels, sort of male hormone levels, what are classically thought of as male hormone levels, but not exclusively male hormones, actually. They come from the adrenal, for example, and increase fairly dramatically in females as well during adolescence. And this is one of the things that happens to children with severe asthma as they go through this period. Looking at adults, remarkably, sort of a classic male hormone, which is DHEA, is very strongly associated with good lung function, such that if you have FEV1, this lung function measure on the y-axis, the DHEAS level, which is circulating DHEA, on the x-axis, you see that there are very few people with these are data from women and very similar data for men, but I'm showing you women here. There are very few women who have a high DHEA level, who have a low FEV1, I'll put it that way. So that right lower quadrant of the graph is basically empty. If you have a good DHEA level, a good androgen level, you're very likely, even if you have severe asthma, to have good lung function. We worked with our urology colleagues, actually, and they knew of a gene, HSD3B1, which was really quite bad for you if you had prostate cancer. This gene had the effect of, variants in this gene had the effect of increasing tissue androgen levels in the prostate, and that had the effect of adversely affecting outcomes. We asked the question about that gene in asthma, and the reverse was true. So if you had the gene that increased tissue androgen levels, it actually improved your lung function, even if you had severe asthma, particularly if you required a lot of corticosteroids. So the gene that was bad for you in prostate cancer was good for you in asthma. These data began to give us the idea that androgens actually could benefit patients with severe asthma. And in fact, some of the corticosteroid effect that we see, really the treatment of choice for pretty much everybody with moderate and severe asthma is an endocrinology treatment. It's a corticosteroid treatment. And some of the corticosteroid effect may actually be an androgen effect. We began to look at this in what's called in silico, because we had a lot of information about mRNA and the airway epithelium of patients with asthma from the Severe Asthma Research Program studies. We had brush biopsies where we could express the mRNA. And one of the things that was really interesting, there are not very many good things about the COVID pandemic, but one of them, the only good thing was that we really learned a lot about the antigen receptor in the airway, because it turns out that that's an important part of the COVID response. And so what we found was, when we started to look, we found that antigen receptor was in fact expressed in the airway epithelium. And that the higher the antigen receptor expression, gene expression in your airway epithelium, the better your asthma was. And one of the markers was inflammation, which is this fraction of exhaled nitric oxide, as well as inducible nitric oxide synthase. So the higher your antigen expression, the lower your inflammation, the lower your FeNO, the lower your inducible NOS. And mediation analysis done by Yi Zhang at Indiana showed that there was actually a causal effect between these two effects. So that antigen receptor is actually preventing inflammation in the airway. It also was, the higher the antigen receptor, the better the FEV1, the better the FEV1 to FVC ratio, which is another marker for airflow obstruction, and the fewer the symptoms. We then went on to look through the Regenstrief Institute and the Indiana database, as well as through very large national databases, and we found that if you were someone who was missing the antigen receptor, either partially or completely, and there's specific endocrinology criteria for that. If you're missing the antigen receptor completely, then your odds of having asthma are substantially higher than if you're not missing the antigen receptor. And so these data have recently been published and given us a whole new view of what's going on in severe asthma. Nadista Morozkina is interested in a trial looking at specific people with low DHEA levels to improve their asthma outcomes. DHEA. This is just a pretty picture. Just if you're interested, this is what a single cell analysis looks like of the human airway epithelium with different genes profiled in different parts of the airway. This enabled us actually to map out, using single cell, a lot of where the antigen receptor gene is expressed and how it functions. So single cell technology is really helping us tremendously. Okay, the second to the last point is that another important variable in asthma severity is low airway pH, and we're studying a treatment that raises airway epithelial pH. This regulation is really quite complicated, and it actually has to do with the pathophysiology, with the causes of cystic fibrosis lung disease, in addition to the causes of asthma lung disease, and a variety of other things. And so these are the pathways that we are studying in the lab to try to improve airway pH in asthma. And part of the reason is that there's now a pretty abundant literature, and this is a bit of a busy slide with the references in the lower left, but I'm just going to stick to the upper left and talk about what kinds of things happen when your airway epithelial pH falls, when the pH becomes more, when the lining of the airway becomes more acidic. It worsens oxidative and nitrosative stress. It promotes cytotoxicity, which is cell injury. It impairs the effectiveness of things like albuterol. It increases the thickness and the stickiness of mucus in your airway and causes it to be harder to cough up. And it impairs the ability of the cilia to clear the airways out. It impairs host defense and bacterial clearance, setting you up for potential pneumonia, and it promotes cough and airflow obstruction. And we have some diagnostic tests that we're working on to identify low airway pH without having to actually go into the airway and do bronchoscopy, but we're also validating with bronchoscopy. And so Mike Davis from our group is working very hard on this, he and John Hunt and others have developed a therapy that raises airway pH in a relatively straightforward fashion. When we found out that a raised airway pH would be beneficial, at least in cell culture and COVID, we asked whether this therapy that Mike Davis is using in asthma, is developing in asthma here in Indiana. We asked if it would also kill the COVID virus, and the answer is yes. And so we're very interested in developing this therapy further, not just as a anti-inflammatory treatment for asthma, but also for a treatment of viral pneumonitis, and particularly COVID. So to summarize what I've told you, treatment for severe asthma should ideally be personalized using precision medicine. Several novel therapies are being studied in Indiana in the Indiana Precise Network. One important variable affecting asthma severity is sex, and we've discovered that androgens may be important in some severe asthma patients. Another important variable is low airway pH, and we're studying a treatment that raises airway pH. And we aim to improve current practice standards, targeting the right treatment to the right patient with severe asthma. And I'll close with that and move on to questions, and I'll check the chat in just a minute. If you want to jot down those links to clinicaltrials.gov or Lisa France's email, that they are there, and I'm happy also by email to answer any questions later on. I'd like to thank several people who've been involved in some of the data that I've shown you. Mike Davis, we mentioned, Laura Smith, in particular, Lisa France, and Rachel Owensby, who are working hard on these clinical trials, as well as Lisa Bending, who's coordinating, Kinsey Mahan, who does really pretty much everything, Lydia Morozkina, who has been instrumental in making many of the DHEA manuscripts and getting those data together, Jim Schmiel, Kristen Klipfer, who you've heard from earlier, and Sydney Ross. Also I'd like to thank the students who've been in the lab here at Riley. I see Taylor is on, so hi to Taylor. Other people here, Yi Zhao, Tim Lam, and collaborators at Case Western, Christy Ross-Josing, James Reynolds, Nima Sharifi in neurology, Jonathan Stamler and Sir Borisman. And at Vanderbilt, we've begun more and more to collaborate, especially in the androgen story, with Don Newcomb. I'd like to thank the Precise Network collaborators and the SARP collaborators, and for the patients in those networks who are working hard to optimize treatment for severe asthma, and funding as well from NIH, Harrington Discovery Institute, and Riley Children's Foundation. And with that, I didn't mention JRT in Virginia. So thank you for your attention, and I'd be happy to take questions.
Thank you. We do have a question. Dan asks, can you give us examples that cause low airway pH that we can address with patients in the clinic?
Yes, absolutely. Great question. The classic example, of course, is CF, because there bicarbonate isn't secreted into the airway epithelium, and so it becomes acidic, and that contributes to airway injury in CF. Of course, we can see that now in many or most patients with really effective therapies that get the CFTR functioning again. But there are other things as well. For example, inflammation in the airway causes a particular type of cytokine to increase in viral infection, in particular, that shuts down glutaminase. And glutaminase in the airway, as in the kidney, buffers airway pH by making ammonia. So there are many conditions. It's not just asthma and CF. For example, patients with COPD will often have a low airway pH, and patients with acute viral pneumonia will have a low pH. And patients with active tuberculosis, for example, will also have a low airway pH. And how would you address that in the clinic? I wish I could change my disclosure slide and tell you what to do. We are developing a therapy, but it's not through clinical trials and so forth. So I can't advertise that. That's perfect.
So maybe the next summit, right, Dr.
Yes, I hope. Yeah.
We do have another question. Are samples from our severe asthma patients in the broader population being collected to look at androgen receptor differences? And do we know what proportion of patients may have these differences?
Yeah, that's a terrific question, Nadia. No, we actually are collecting biopsies and brush samples in the context of the program project grant, but not anything like the volume that we did in the SARP. And so fortunately, though, the data are preserved in the SARP. And so we've been able to go back and answer that question. And nobody really knows truly, Nadia, what's the normal androgen receptor level in the airway. But we know that in the relatively small control population from the SARP, patients with asthma tended to be much lower. And I would say it was at least 2/3 of patients with asthma tended to be lower than controls. But that's sort of a rough sort of retrospective estimate. We'll have some prospective data from the PPG, and that's certainly an important thing to look at moving forward. How can we tell if somebody has decreased androgen receptor expression in the airway? We don't know that yet. All we can say is whether you have decreased circulating androgen receptor ligand, whether you have low testosterone or low DHEA. And those are the patients that we're going to start out by aiming to normalize the levels and see what happens to asthma control. We do know, Nadia, I would make one other point, and that is that people on high dose inhaled corticosteroids or systemic corticosteroids for severe asthma do tend to be low.
Is that potentially the effect of the medication, or is that because their asthma is severe enough that they keep being symptomatic and therefore we keep giving them, or both?
I think it's both. There's substantial evidence, including that genetic evidence that I showed you, that that there's fundamentally a problem with androgens that's not caused by corticosteroids. In an androgen insensitivity in the airway. But I think that problem is compounded by taking a lot of corticosteroids. And I think it'll be a slow process to separate those two. Dr. Moroskin has done a study looking at women with non-severe asthma and low levels of androgens and shown that if they take DHEA in a carefully controlled way, it improves their FEV1. There's another study of inhaled DHEA that Sally Wenzel did showing that it improved asthma symptoms. But I think those studies are still in their infancy, and I'm not at a point where I'd recommend that you get a DHEA level and treat with androgens, especially if you're an athlete, because then you'll get busted for performance enhancing steroids.
Is there, one other question, is there any thought or mechanism where, say, an exhaled biomarker could relate to DHEA and androgens?
That would be great if it did. We don't have that yet. That's something that Mike Davis, I think, would love to work on, but we're not there yet.
Yeah, great, thank you.
Sure. Thank you.
We are out of time.
Okay. And I don't see any other questions.
I don't see any other questions either. So perfect timing, it looks like. Thank you so much, Dr. Gaston, for being here and that information. And thank you all for attending and learning with us today.